Got to examine both hands anyways, right? So patient presents, you're going to take a history, you're going to do observation. I'm going to look and see if they can rotate their arm, see if there's any major atrophies. So after we've done the history, we've done the observation, I'm going to go on and start this exam with a neurological test. So what I'm going to have you do is close your eyes and just relax your hand. Is that comfortable for you? Okay, I'm going to just do a couple of little touches. So you tell me which place I'm touching you.
Wrist. Hypothetical eminence. Web space. Little finger. Index. Middle.
Good. Can you turn your hand over? Good. Thank you.
Ring finger. Thumb.
Good. Excellent. Okay. So the other thing you can do is you can take a paper clip and make it a 2-point discriminator. So what I'm going to do is I'm going to touch you. I'm just going to push like that. Okay. So you're going to tell me if you feel 1 or 2 fingers or 1 or 2 points. So distance here is about 4 millimeters. 4 to 5 millimeters is normal. You can widen it if they're as you're moving proximal. But we're mainly looking at this distal area. So close your eyes. Close your eyes, not your fists. Thank you. Good. And tell me if you feel 1 or 2.
1. 2. 2. 2. 1. 2. 1.
Good. Turn your hand over. Good.
1. 1. 1.
Good. Relax. And if you noticed on the video, I hit her with 2, but as I moved proximal, she couldn't discriminate. So you'd actually have to widen that. And those values are published in the literature. So we've done the sensory part. She did really well with fine touch. She did really well with 2-point on her finger. So now we're going to quickly check motor. So we can get the ulnar, median, and radial nerve cutaneous distribution pretty quickly. We certainly, if they have any neck considerations, we're going to clear the neck like we normally do. But what I want you to do is extend your thumb back as far as you can. That's going to activate the extensor pollicis brevis. Don't let me move you. So she's a little weak in that area, has a little difficult doing that. Try it again. So she's a little weak in that area. So now what I want you to do is abduct your finger. So we're going to do abductor, digiti minimi. She's doing them all, which is fine. But I'm going to apply a little bit of a load here. That's going to be ulnar. If I want to get the very last ulnar nerve, I'm going to check this first dorsal interosseous. So I'm going to apply a load here and see if she's strong there. So really strong in the first dorsal interossei. And then obviously we checked the other side. Now we're going to have you abduct your thumb. So just lift your thumb up here. And now this time I'm going to keep the load right at the base of her thumb to check her abductor pollicis brevis, which is a median nerve, and that was also weak. I don't know if she has some thumb pathology or something going on there. So that would be the sensory components with that. So now we're going to check her range of motion. So we can do a gross screen of her range of motion. We can basically bend her elbow and have her extend her wrist back as far as she can. Take my little goniometer. I'm going to have you turn that way for the camera. Thanks. And I can line that up to get that motion, but I'll be honest, most of the time we just put it right across that skin to get that motion. That probably looks a lot more accurate though. That's about 75 degrees. Now let's go into flexion. Good. And that's about 65, 70 degrees of flexion. But I see a lot of people just do this, which is a diminished amount of motion. Okay, so that gives you gross wrist motion. If we're going to do radial and ulnar deviation, have them extend their hand out and then have them actively ulnarly deviate. I can measure that orientation, radially deviate. Remember, there's always going to be less with radial deviation. If we're looking at individual fingers, we're going to bring them back up like that. Go on and make a fist. So she makes a full fist, no problem. But let's just imagine she has a pathology. Relax. And so what I want you to do is make a half fist. Don't come all the way down. Good. So now I can measure that distance between there. She's sort of scrunching everything up. Let's make it a quarter of a fist. I can measure that distance. Go on and gently squeeze down your ring finger. Good. Stop right about there. So I see that motion is there, and that ends up being about 2 centimeters away. So I can use that as a quick gross measurement. If I want to measure individual fingers, though, what I would do is make a full fist, far as you can. So now I'm going to measure that distance. So that's about 110, 105 degrees. I'm going to look here at her distal phalanx. That's just a little bit past 90. All right, good, relax. So now just try to make a fist like this, like a claw, and then I'm going to measure that distance right here for a ring finger, and I can do all her other fingers as she goes through those motion. One thing that's really interesting that I've learned working with the hand therapist is those all give you joint motion, but if you're interested in the dorsal or volar compartment, which is often tight, we can also measure that. So I'm going to have you extend your elbow, make a fist, and then I want you to flex down as far as you can. So you notice there, and can you turn over that way? Good, go down as far as you can. She doesn't flex very far. So I think her last motion was around 60, 65. That's just over 50 degrees. Does that feel tight to you? And so this whole dorsal compartment is tight. Her wrist extensors and the wrist extensors and the finger extenders are probably tight. So that measures the dorsal compartment. That was interesting to me for my wife. And then extend your hand out, fingers together, fingers together. Now we're going to do extension, right? So we're going to measure that same amount of motion. Hold your hand up there. And here she goes to about 66, 65. Feel a good stretch with that? You went further than you didn't try it last time. You look like you were being deficient. So that was closer to 75. So not as tight this way, but definitely felt tight going that way. Yeah. All right, so that would measure muscle length, range of motion. I can apply overpressure with any of these, so anybody that has limited motion, I can go on and try to load that tissue. I think I've already shown this to you in class, but if you bring their arm up, and what I want you to do is I'm going to extend your little finger, and I want you to pull down as far as you can. Good. That really checks that intrinsic length. See how she wants to flex that finger? Relax. So if I really hold her into a little hyperextension now as she pulls down, she can get there, but you want to make sure that that's not too tight. I think Amy had some restricted range of motion when we did that, go on and pull down. Good, so she can get there, but that intrinsic position, go on and make your fist like that and try to extend your fingers. Extend these joints, good. Somewhat of a stretch with intrinsic tightness. So some of those are really important additional measures to look at muscle length. So we've done range of motion, we've done sensory testing, so we still have resistive testing and special tests to do. So for resistive testing, I basically put them in a position and then have them hold instead of explaining stuff to them. So make a light fist. I want you to extend your wrist and try to cock it up that way. So I'm going to get the radial side, hold, don't let me move you. Good. Now push it out. Good. Now hold, don't let me move you. So I'm going to bias the ulnar side. A little weaker going in toward the ulnar side, so she's a little weaker on that side of her wrist. Flex up, bias it that way, pull it over there. Good, don't let me move you. Again, a little weaker that way, a little wrist pop, sorry. She's got a little wrist instability. Go on and flex, bias it that way, don't let me move you. Much stronger on the radial side than on the ulnar side. So that gets the wrist flexors and extensors. As we do the individual tissues to bias the extensor digitorum, we're going to have them extend here. Just hold there. Good. I'm sorry, I said the wrong thing. Extend here. Good. And I'm going to apply resistance there. So that gets the extensor digitorum. To get the PIPs and DIPs, we want them to come up in here, and what I want you to do is straighten your fingers out like that. Good. So I'm looking to see if they can control that. I don't really typically load that. Those are the lumbrical muscles. See if they can get that nice flat fist. Really straighten them out. Good. So that indicates her lumbricals are working well with that motion. So to get gross flexors, I can have her sort of interlock her fingers with mine. Hold, let me pull you down. It doesn't really bias anything one way or the other. It just sort of gives you a quick gross test. But if we want her to isolate her FDPs, so now I'm just going to have you flex this finger up. Good. Relax. I didn't stabilize you enough. Just this finger, just that digit. Hold. Good. That gets the FDP. I can do that at multiple segments. Light resistance. If I want to get FDS, then I'm going to block all of these other fingers out. Flex that down. Notice that she flexes it a little there, but I'd apply the resistance at the proximal component because you've really sort of biased the FDS. FDP, it really can't do anything. So this is all FDP as they go through that motion. And I can do that at multiple fingers. Hold, let me move you. Ooh, a little weak there. And this would be a positive test a lot of times with FDP and FDS for ring finger, especially, is probably the most common flexor tendon injury as they go through that. We already did abductor, pollicis brevis. We did extensor. We can have a thumb extend. Go on and extend your thumb. If I work at the base, that gets the brevis. If I work at the tip, that gets the longest of the thumb extensors. Both a little weak on this particular patient. We got some rehab to do, Mrs. Wool. Okay, I think that was everything. Oh, no, I still forget that one. I don't do the Allen's test very often, so I got to do the Allen's test. So this is to check neurovascular patency. I know we can do a lot of squeezing and looking for capillary refill, but somebody that's got a chronic hand problem, or you're worried about good blood supply after a wound, you should do Allen's test. So basically, Allen's test is I'm going to occlude the radial and ulnar arteries, and then have her squeeze, relax 4 times, and then I'll release one side and watch it redo. Sorry, thanks for helping me out with that image, Christine. Good. Open and close, couple times more. Good, now open, and you can see her blood supply is really good. You can do the same thing on the radial side. Okay.